Okay, that was extraordinary. Thank you. And you can see why so many of us rely upon Jessie for her expertise. Not only is she extraordinarily skillful, but extremely compassionate, again, for this very vulnerable group of people. And I hope you do that study about methadone. We are having an extraordinary problem in Chicago with our patients who are in methadone programs being kicked out of the programs because they now have a serious illness, and the methadone directors don't perceive that they have the expertise. And that's causing a lot of existential distress on the part of us as clinicians and the patient, obviously, and also some regulatory concerns. Questions, I'm sure there are many. So shall we start? Please come. Oh, we've already got a Twitter question first, and then we'll go to the mics.
We have a question from Craig Blinderman on Twitter, and he asks, cancer pain and pain in patients with serious illness and history of substance abuse or high risk for opioid use disorder can be managed effectively with methadone or buprenorphine. Why not advocate for this as a first-line strategy if no contraindications?
Right. So I think the way I want to approach this question is that, first of all, if somebody has an opioid use disorder, regardless of anything else, methadone and buprenorphine are evidence-based treatments. Agree 100%. So if somebody has chronic pain and an opioid use disorder, regardless of serious illness, in my practice, I reach for buprenorphine. The reason for that is because I'm not a methadone clinic, right? So this gets back to the issue in this case, and then you throw serious illness into it, okay, but the same issues apply. So then the issue is, do we do buprenorphine? Do we do methadone? Well, I can prescribe buprenorphine. The patient has to go to a methadone clinic to get methadone. Methadone for pain is dosed very differently than methadone for opioid use disorder. So then it becomes a conversation with the methadone clinic that often doesn't feel comfortable. So this is why we need, I agree, I hypothesize the same thing that you do, Craig, about this, and then the question becomes, we need to A, do a study that really looks at this, and B, this business of methadone being separate from our healthcare, from our medical care system is a historical vestige that is exceptionally problematic and creates unnatural problems like this.
Why don't we start here?
Sure. Dan Alford from Boston University, Boston Medical Center. I'm general internist, addiction medicine, and do a lot of education on safer opioid prescribing. So thanks, Jess, for that presentation. So just a couple of issues. I just want to reiterate that you cannot prescribe legally methadone for the treatment of an opioid use disorder outside of a federally licensed methadone clinic. So in a case like this, you have to be very clear that the methadone is for pain, even though the person has a history of an opioid use disorder. But to diagnose an opioid use disorder in that patient and continue to prescribe methadone, even though it makes sense pharmacologically and clinically, it is illegal. So we need to be very, very careful. So we really are limited to using a medication like buprenorphine if we are waivered to prescribe it to treat both things, which is actually something that probably could be done more often than is.
Correct.
So it's not just that there's a lack of evidence basis for it, it's that it's illegal. But the
Correct,
point,
yeah, agreed.
Yeah, I know you do. And I just wanted to reiterate.
I know, right.
The one point I want to make is, one thing that you didn't address is that there is certainly experimental studies that have shown that patients with a history of an opioid use disorder, whether it's active or in recovery, on medications like methadone or buprenorphine or not, tend to have increased pain sensitivity compared to matched controls. And so, whether they were born that way and therefore they were more likely to develop a use disorder in the first place after getting exposed, or the use disorder itself resulted in a decreased pain tolerance. But it just seems that it's an important thing to use clinically that I tell my patients. I realize that you may actually be more sensitive to pain than someone who does not have a history of addiction. And I think there's that piece and the piece that patients feel because of their history of a use disorder that they're going to be under-medicated. And so there's some anxiety associated with that. So I think there are a lot of things that we can do to reassure these patients that, one, we understand that their sensitivity may be increased, but also that because they have a history of use disorder, we're not going to undertreat them. We're going to actually be more aggressive. And I think that goes a long way in helping some of these patients, deal with their pain, realizing that we appreciate that they have a different experience. Yeah,
Agreed.
I think I'm going to ask people to keep their questions or comments kind of short, otherwise we won't be able to address the long line of folks waiting. So next.
My name is Barbara Herbert. I'm a community-based addiction medicine doctor, and I do some work with chronic pain and high opioid users in a federal demonstration grant. And my question is, how do you think about the use of alcohol and cannabis in people who may be in remission from their opioid use disorder and have severe pain or anxiety?
And let me clarify, when you say how do you think about alcohol and cannabis, can you expand on?
Yes.
I can think of a lot of different responses to that, but I want to make sure I.
Yes, in particular, people who are self-medicating, the ancillary problems that they're dealing with cannabis or alcohol.
Yeah, and that's I'm glad you asked that because it's a really common thing, right? So, and I feel sort of like, I know there are a lot of other people in the room who may have thoughts on this, but I will say, so substance use disorders are often polysubstance use disorders, right? As you well know. And so if I have somebody who I'm treating who has an opioid use disorder and is using alcohol in a way that is risky or also constitutes an alcohol use disorder, then I try to address that directly. Where it becomes, and same with cannabis, I think where I think the rubber hits the road a lot is in somebody who's on long-term opioid therapy and or long-term full opioid agonist therapy or buprenorphine, who's also doing that, who's also maybe has an alcohol use disorder or is using cannabis. And then it becomes a risk-benefit conversation with that patient. In addition to addressing the actual alcohol use disorder present or cannabis use disorder, a risk-benefit conversation with the patient. But those are all sedatives. I mean, it makes me very nervous. When I have somebody who's on opioids, who's using alcohol, I mean, I try everything I can to try to get them to be in recovery from the alcohol as well. Does that address your question? I feel like I may not have, but.
Where there's obvious other substance use disorder, it does. But where people, for example, have medical certification for cannabis and their cannabis levels are remarkably stable over time. How do you think about that?
Yeah, it's hard when other providers become the source of something like cannabis so I guess I can take a step back and say that my view on medical cannabis is that we don't have the evidence base and the cart is before the horse, as others have said before me. So, if somebody then I actually have a patient like this right now who developed a cannabis use disorder to the cannabis that he's certified to get, and not from me, but from somebody else. And, that definitely changes the way I think about his long-term opioid therapy. It makes me very concerned. It's a risk benefit always.
And if he hadn't developed a cannabis use disorder, but was, for example, substituting cannabis for benzodiazepines.
So then I hate to keep sort of saying the same thing over and over, but I think it is a risk benefit always. So if the benefit of him using cannabis outweighs the risk, so I mean, if he's using it for pain, he really feels like he's getting benefit, he's not using other substances that could be more harmful, then that's one thing. But it is a fine line between that and something more. And so always sort of keeping one's eye on that. But I mean, there are plenty of people who I believe can use cannabis safely while being on long-term opioid therapy.
So we knew this would be a session that would evoke many, many questions and comments. And I do have a little permission to go a little bit over because we have a whole hour for lunch, but I'm not going to stand between you and lunchtime. So we'll just use a few extra minutes. Anything on Twitter? Nope? Okay. Please. Thank you.
Hi, my name is Jerry Miller. I'm from the National Institutes of Health, National Institute of Nursing Research, Office of End of Life and Palliative Care Research. Thank you, Dr. Merlin, for your candid remarks about the need for a contemporary knowledge base and the need for evidence. But I feel compelled to have a call out to the efforts of NIH and our other agencies to try to address this. For the longest time, NIH has had a funding opportunity announcement called they've changed it, so I'm going to check that I'm reading this right. Mechanisms, models, measurements, and management of pain. It's a clinical trial optional, so it has always been that it cannot be just clinical trials, but it could even be exploratory, developmental, data-driven. We found over the years that we could not bring in individuals that are interested in pain and serious illness. So we just launched a couple weeks ago at NINR 2 funding opportunity announcements that focus on symptom management, of which one of the primary objectives is to look at pain. But we're calling for attention to how pain interacts with behavioral, mental health issues, the family caregiver, and social determinants of health. We want to ramp up the evidence base because, as you probably know, the NIH, the Department of Defense, and the VA have an $81 million initiative that really looks at looking at pain management in real-world pragmatic settings and real practical approaches. And these pragmatic clinical trials in healthcare systems have been modeled after a very successful pragmatic clinical trial paradigm that we're using that not only incorporates being in the real world setting, but understanding patient reported outcomes and that very close link between the clinician and the individual or patient themselves. So I hope that I can put a call out for all of you who are saying we don't have evidence. We're ready to support evidence. Where are you? Thanks.
Game on.
Excellent, thank you. Next, quick question.
Hi, I'm Heather Wargo. I am a patient advocate for incurable painful disease patients, specifically extremely rare painful disease like chronic pancreatitis, interstitial cystitis, the painful diseases that do not really have treatment options. So what I'd like to ask you is, for these patients that really don't have a lot of treatment options and they are in a lot of pain, a lot of patients are getting yanked off their opioids anyway. And are any of your colleagues actually are you doing studies on these patients now? Because we have no evidence base on long-term opioid use versus being off opioids because it's inhumane to do those kinds of studies. However, we're yanking patients off their opioids anyways. So are we studying these patients as they're not having their opioid therapy and kind of like doing a control with the patients that are still on their opioids with the patients that are off their opioids so we can see meaningful data and see how is this going with these patients that are off the opioids versus them, so we can have some meaningful data and see what long-term opioid use really looks like versus the patients that are in chronic pain off the opioids.
Thank you very much for that question. I think it highlights the distinction between somebody being tapered off of their opioids or switched to buprenorphine because of concerns of problems versus somebody being kind of yanked off their opioids for no particular clinical reason, but more so driven by insurance, driven by local policy. And I think Dr. Cortez touched on this a little bit this morning that, we do have some evidence about what it's like when you engage in a shared decision-making model with the patient, where you sit down with the patient and together come up with an idea about tapering because it seems to be what's best for the patient at that moment. And people tend to do okay, but then we don't know what happens when you just yank people off of opioids other than a lot of really disturbing anecdotes that are bubbling up to the surface. So we need more work in that area. And I see that Stefan's at the microphone. That was part of your talk this morning. I don't know if you wanted to add to that.
My name is Stefan Kirtes. I failed to disclose that I'm primarily an addiction scholar. At the beginning this morning, most of my funding has been from NIDA. I should have mentioned that. I come at this pain issue from addiction first. I will say that there are 3 or 4 abstracts that have been presented at public meetings about people being discontinued and what the outcomes are, but they have not gone through peer review and been published as papers. So it'll be much more robust about a year from now. I have a question for you, Dr. Merlin, about this other way of diagnosing addiction, and it really is manifest in both among practitioners and among the education I've received in the VA, where some of the leaders of our VA DoD guideline have taken the approach that we need to stop the opioids because they're dangerous. People have shorter lives if they're on opioids. You should taper slowly. And if the patient doesn't seem to be coping, you have uncovered opioid use disorder, which now merits treatment with buprenorphine. So the idea is sort of a stress test for opioid use disorder based on a taper of a previously prescribed opioid, and if the patient can't cope, you now have diagnosed an addiction. And I guess I want to know, do you feel that's consistent with the strategy and approach you're thinking about these patients?
So I'm not sure if underlying that question is that one is trying to uncover.
One is trying to remove a dangerous substance is the general philosophy. I've received this on many national phone calls.
Right. So I think there are a couple issues there. One is the idea of wholesale tapering people because you want to remove a dangerous substance. And then the other is, so that's one path,
yeah.
Right? And I do think probably in some of those patients, I have seen probably what was simmering opioid use disorder that was being partially treated by full opioid agonists be uncovered. Yes, that can happen. I also think that when there is a shared decision-making model, I have also seen people who are being tapered develop, the same thing, that they have probably what's been a simmering opioid use disorder. So if somebody during the course of a taper develops an opioid use disorder, my strategy is to switch them to buprenorphine and treat it. But I don't endorse the wholesale kind of tapering of people and then, it's okay just to taper everybody. We'll just watch to make sure they don't have an opioid use disorder. I think those are different things. Is that what you're getting at?
It really has to do with the criteria for the diagnosis. I diagnose cardiac disease with stress tests all the time. This is sort of stress test for OUD.
I guess. I think inherent in your question is you don't think of it that way either. And I don't either. Nobody wants to induce somebody into an opioid use disorder. If the benefits of opioids are outweighed by the risks, and it's reasonable to taper potentially or switch them to buprenorphine if they have an opioid use disorder. And if they develop one along the way, you got to treat the opioid use disorder, but let's not try to uncover a population of opioid use. Let's not give the whole population a stress test.
Thank you.
Yeah.
Do I hear any other questions? I think we're going to have some lively conversations over the lunch hour. Many thanks to Dr. Merlin for her excellent presentation.
Thank you.
And for all of the presentations this morning. I think we're returning at 1:15.
Yeah.